All right, welcome to Brain Health with Dr. Nissen. Today we'll be talking about psilocybin and its research within the psychiatric field for psychiatric indications. Hope you find it to be an interesting discussion. I do want to remind everyone, as is written at the bottom of the slides, that this presentation contains discussion of experimental and illicit substances. This presentation is meant for general informational purposes only and does not constitute the practice of medicine or other healthcare services, including the giving of medical advice. No doctor-patient relationship is formed. This presentation is not meant to advocate for the use of illicit substances. It is recommended that you do not use illicit substances or perform any other unlawful act. So, some important points about psilocybin. Psilocybin is a tryptamine psychedelic with a good safety profile that's been noted in several different trials, several different studies. It works by serotonin 5-HT2A receptor partial agonism, meaning that it binds to the serotonin receptor and in a way that activates it, but with a bit of a cap on the degree of serotonergic activity. So this is something we'll talk about in a little bit, but it's very important when thinking about the toxicity potential. So psilocybin-assisted psychotherapy appears to have benefit for multiple indications, including depression and substance use disorders, particularly tobacco use disorder. Psilocybin-assisted psychotherapy has been safely conducted with medically ill patients, like those with cancer, AIDS, and this is particularly seen in some of the Johns Hopkins studies that have been published in people with life-threatening illness. So this is something that I'll go into more detail in a little bit. And it's generally been found to be well tolerated with risks related to drug-drug interactions, including an increased seizure risk that's noted with lithium, as well as the risk of intense psychological effects or psychosis. So what is psilocybin? Well, psilocybin is a substance that's naturally found occurring in mushrooms, lichens, truffles, and especially in North and South America and Europe. There are about 200 species of mushrooms that contain psilocybin, and it's been used in several indigenous cultures. And there's actually a stoned ape theory, which is this theory related to the fact that, or the sort of hypothesis that these mushrooms could have played a role in human evolution through neuroplasticity sort of benefits that they have, encouraging the prefrontal development of the prefrontal area of the brain. Psilocybin is a Schedule 1 illicit substance, so kind of falls within the class of other illegal street drugs. But there has been a decriminalization movement that has been gaining steam in places like Oregon, Colorado, several other sort of municipalities in Massachusetts and others. And it's considered a classic tryptamine psychedelic, along with LSD and DMT being two others that you may have heard of. And what that means is that these are serotonergic psychedelics that share many chemical similarities. It is a partial agonist at 5-HT2A receptor, which is very important. So it's not a full agonist. So this puts a roof on the effects. And this means that there's also low overdose potential associated with psilocybin. I think one way to sort of think about it is comparing to opioids. So you can have something like a full opioid agonist like fentanyl, and so there's no roof, and so it's easy to overdose, and that's why fentanyl is so deadly. But with something like buprenorphine, you have this partial agonism, and it creates a roof of sort of the amount of activity. And so similarly for psilocybin, you see this partial agonism, which limits sort of its potential for overdose, which is why some consider it the safest psychedelic, which is a reasonable thing to think, and I think it's something we'll talk a little bit more about as we go through. Psilocybin as a substance has been fast-tracked by the FDA as a breakthrough therapy due to its promising results being found in some of its trials for treatment-resistant depression. So let's talk a little bit about psilocybin structure. Rickley and colleagues in 2016 published this paper, comparing the chemical structures of tryptamines, LSD, mescaline, and psilocybin. You see on there psilocin, which is the active form of psilocybin after it's metabolized. And so you can see the similarities here in structure between the psilocin and DMT. So how does psilocybin work? Well, psilocybin is a prodrug, and it's converted to the active compound psilocin. So the psychedelics that it has are largely mediated by this 5-HT2A receptor activity. There is some activity on other receptors, but we're focusing mostly on the 5-HT2A receptor for now. And it acts as a partial agonist, like I had mentioned. There's also some binding at other receptor sites, as I mentioned previously. There's, for example, the binding at 5-HT2B has raised some questions about risk of valvular heart disease with long-term use of psilocybin. The 5-HT reuptake inhibition, serotonin reuptake inhibition is probably not very clinically significant. There's also minimal activity on the monoamine oxidase enzymes, or VMAT2. And it does not increase intrasynaptic serotonin, which is important because since it is a serotonergic psychedelic, many wonder whether there's risk of serotonin syndrome when being combined with other antidepressants, with SRIs, like serotonergic antidepressants. So it's a really important factor to consider. So how does psilocybin 5-HT2A receptor activity compare? So this is kind of what I was mentioning before. With full agonism, that's like serotonin itself binding to the 5-HT2A receptor, you can get full agonism. This would be sort of akin to fentanyl binding to an opioid receptor. With psilocybin, there's partial agonism, which puts a ceiling effect. And then, to compare for antagonism, there's 5-HT2A antagonism by mirtazapine and trazodone. For inverse agonism, there's 5-HT2A inverse agonism by atypical antipsychotics, which is interesting because as we think about psychedelics as a class, you can think of these classic tryptamine psychedelics like psilocybin or DMT that have these partial agonism effects, and you can think of atypical antipsychotics, which are very commonly used in schizophrenia, in bipolar disorder, in treatment-resistant major depression. You can think of them as anti-psychedelics because they're inverse agonists at the same receptor. And so that's really interesting to consider, that there are sort of pro-psychedelics like psilocybin, and there are anti-psychedelics like the atypical antipsychotics that we're using. Due to the partial agonism, there is a different intracellular cascade that can occur, and there's also no significant association with serotonin syndrome, like I mentioned. So I just mentioned the intracellular cascade. So this leads to an important discussion about functional selectivity. So the impacts of psilocybin on the brain are not only through this partial agonism of 5-HT2A leading to this sort of serotonin cascade, but what's been found in this, you can read about it in McKenna and colleagues' 1990 paper, is that there's a difference, there's two different cascades. There's a serotonergic cascade, but then there's also what could be called sort of a psychedelic cascade, in which the conformational change of the G protein coupled receptor and the cascade of secondary messengers leads to recruitment of glutamate receptors. And it's thought that this cascade involving the glutamate receptors is what kind of mediates the psychedelic effects of psilocybin, and that's what makes it different from just serotonin alone acting on the 5-HT2A receptor. And interestingly, even more than this is that whenever there's G protein coupled receptors and secondary messengers, what this means is that you have a process that's occurring more slowly and sort of evolving over more time. And what this means is that there's sort of an epigenetic fingerprint that's left on genes and gene expressions long after the drug is eliminated. Related to this, it's been found, that folks after using psilocybin have actual kind of persistent changes in personality, specifically within trait openness. So that's to say that the long-term impact of using psilocybin, one of which is that it leads to more trait openness, which in the Big Five psychology means openness to experiences, so kind of more curiosity, more flexible thinking, more openness to things that you're not familiar with, versus kind of a more closed-mindedness that's on the lower end of that trait spectrum. So this phenomenon of the epigenetic fingerprints that are left due to these differences in gene expression, the recruitment of glutamate receptors from the secondary messengers, is really important, and so it can lead people to sort of be affected for a long time after the drug is eliminated from the body. The tolerance that can occur over time is really important to consider as well. So various serotonergic drugs will downregulate or diminish the number of 5-HT receptors, and that's true for psilocybin as well. So this causes a rapid tolerance. After psilocybin is used, usually folks will need to take much higher doses in order to have any sort of psychological effect. So what are tryptamines? I mentioned tryptamines before. It's a class of hallucinogenic substances that are chemically based on the tryptamine structure, which is the bicyclic structure that you could see in that other slide, consisting of a benzene ring fused to a pyrrole ring. So there are endogenous tryptamines, which include serotonin and melatonin. So serotonin itself and melatonin itself have similarities structurally to psilocin, the active compound of psilocybin, and to DMT. And that's why, both of them bind at the same receptor, at 5-HT2A. And it's Hendricks and colleagues in 2014 and in 2018 showed there's an association with these tryptamine use and lower rates of recidivism or return to incarceration, which is interesting because we often think about drug use being associated with incarceration, but something about psychedelics reduces that risk. And but there is a risk of triggering psychosis or mania, which is why for many studies it's considered a contraindication if somebody has a diagnosis of schizophrenia or bipolar 1 disorder, that if they were to take psilocybin that could be triggered. So what is the role of set and setting? Well, Lewis and colleagues in 2017 had a really great neuroimaging study where they were looking at psilocybin and the sort of subjective effects. And what they found is that these subjective effects were kind of more audiovisual in nature, elementary imagery, complex imagery. So, kind of being in this medical setting led folks to have more of sort of a hallucinatory experience, versus Smigilski and colleagues in 2019 looked at a mindfulness-based psilocybin setting and found that there were less hallucinogenic effects and more mystical effects. So they noted more blissfulness, unity, sacredness, and embodiment. So what does this mean? It means that set and setting matters. So the experience that somebody will have with psilocybin depends completely on what environment and what psychological state they're in when they're taking the substance. So if they're in a substance where there's mindfulness, maybe where there's some sense of community, maybe where there's some kind of either outdoor space or connection with day-night cycles or things like that, that may be more, well, and in the context of therapy as well, that those sorts of contexts may help for the psychedelic experience with psilocybin to be more mystical versus if you were to have the substance consumed in a very medical setting, in one that's maybe devoid of other people or is devoid of kind of natural light spaces, plants, things like that, it leads to more sort of hallucination and less of a mystical experience. So Vollenweider and colleagues in 2010 published this paper looking at the subjective effects of psilocybin versus ketamine, and you can see here that a known effect of psilocybin is these elementary visual alterations, audiovisual synesthesia, vivid imagery, and that's different than some other psychedelics like ketamine, in which there's less of these sort of visual hallucinations, the elementary visual alterations and synesthesia, and for ketamine, for instance, there's more disembodiment or dissociation that occurs. But the point is that we can possibly shift the psilocybin psychological experience and subjective experience by preparing somebody psychologically and putting them in a setting that encourages their experience to be more mystical. And by mystical, I mean having those things in the orange at the bottom there, more of a blissful state, an experience of unity, religious experience, or insightfulness, which is more associated with the positive psychological outcomes. So that leads to the next part here. So how is the psychedelic experience measured? So for several of the trials, they use what's called the Mystical Experience Questionnaire, or MEQ. The revised version by McLean and colleagues in 2012 used a 4-factor structure where they were covering the dimensions of the classic mystical experience. And so those 4 factors were mystical, positive mood, time and space, and ineffability. These factors and the mystical experience questionnaire sort of scores are associated with longer term benefits of psilocybin. So somebody does have a treatment session and their MEQ is measured. The folks that have more of a mystical experience are the ones that also have, the greater changes in their in much of the psychiatric outcomes that are being looked at, be it depression scores, anxiety scores, things like that. So having a mystical experience is associated with long-term benefits of psilocybin. It's correlated with higher psilocybin doses, so that at higher doses, more likely that the experience is mystical. It's associated with personality change, increase in openness trait, like I mentioned. So folks that do do a treatment with psilocybin and they do have more mystical experience, that's associated with greater trait openness developing, and is also a mystical experience is associated with surrender or preoccupation prior to the ingestion. So the more that one can sort of surrender and be open to the experience and where it's going to take them, possibly more likely that they have a mystical experience. So how has psilocybin dosing been studied? Well, the trip typically, or the treatment, is 4 to 6 hours for psilocybin, and there's a 30 to 60 minute onset. The onset can be hastened a bit by using heat or acid, and what that does is it quickens or it hastens the conversion of psilocybin to psilocin. So microdoses that have been used in studies are 0.1 to 0.3 grams of dried mushrooms. The quote-unquote museum dose is zero point 0.4 to zero point 0.8 grams of dried mushrooms. A low to medium dose is 1 to 2 grams of dried mushrooms. A quote-unquote macro dose is 3 to 5 grams of dried mushrooms. And so context for all of this is that approximately 1% of dried mushrooms is going to be pure psilocybin. And so in many of the trials that I'm going to mention, they're looking at 0.2 to 0.4 mg per kg of pure psilocybin, which corresponds to roughly 1 to 2 grams of dry mushroom equivalent, which is that sort of low to medium dose that is mentioned above. So how is psilocybin impacted by the body and environment? What are the pharmacokinetics? So psilocybin does slow down GI motility and decreases absorption of food. Tolerance develops very quickly, like I mentioned, due to the downregulation of the serotonin receptors. There's glucuronidation that occurs by the liver, so UGT1A10, and then after it's glucuronidated, then it's eliminated by the kidney. Importantly, there's no significant cytochrome P450 activity, which means that that helps to minimize some of the drug-drug interactions. And clinical trials have excluded subjects with poor kidney function or liver metastases, and at least one of the reasons is because of the role of the liver and the glucuronidation and the kidneys in removal. But there is some evidence to believe that it can still be safe to use in single doses with this population. There are minimal drug-drug interactions due to the minimal cytochrome P450 activity that I mentioned, and also limited monoamine oxidase enzyme activity, which is important compared to other psychedelics like ayahuasca, which does have a really important monoamine oxidase inhibition factor to it, which makes it dangerous or possibly dangerous in combination with SRIs, serotonin reuptake inhibitor, psychiatric medications, antidepressants. So this does not have that. Psilocybin does not have very significant MAO activity. Psilocinoquinolone also is something that people may notice if they ever see mushrooms that are bluish in appearance. It's the oxidated form of the mushroom. So does psilocybin have drug-drug interactions? So Nayak and colleagues noted an increased risk of seizures when combined with lithium. So this is a really important consideration, very specific one to be aware of, that maybe to practice, maybe once this is legalized or being used more widely to be careful in folks that are taking lithium. Keeler and Picorni both published studies that looked at diminished effects of psilocybin when combined with 5-HT2A blocking antipsychotics, like I mentioned, the atypical antipsychotics, as well as serotonin agonists and SRIs. So, taking atypical antipsychotics or even taking antidepressants may diminish the experience. It's thought that typical antipsychotics may increase anxious ego dissolution, is something that was found in a study that was a difference in sort of how the ego dissolution, it may be a bit more blissful for folks not on typical antipsychotics. It may be more anxious and distressing for folks that are on typical antipsychotics. There is some theoretical additive vasoconstriction when combined with migraine serotonin agonists like triptans that is important to consider. And then there's decreased metabolism when combined with diclofenac, probenecid, or cinacalcet, and that's related to the glucuronidation, UGT1A10, 1A9 inhibition, and alkaline phosphatase inhibition. How do psilocybin and SRIs interact? So SRIs, serotonin reuptake inhibitors, antidepressants, sort of the most commonly used antidepressants. So there is less interaction than other psychedelics due to the 5-HT2A partial agonism, meaning that serotonin syndrome is unlikely. So like I mentioned, there's sort of a roof in the effect of the partial agonism of the psilocybin on the 5-HT2A receptor. And there's also, minimal increase in the amount of serotonin at the synaptic cleft. So what that means is that there's not very significant risk for serotonin syndrome. Interestingly, though, the psilocybin effects are often attenuated on patients on SRIs. So this is thought that maybe folks that have been on antidepressants for a while, their body sort of develops some tolerance or becomes accustomed to higher serotonin, and so this means that the impacts of the same dose of psilocybin are less noteworthy. And so, it's sort of a risk-benefit analysis to consider whether one should stay on their SRI as they're doing a psilocybin treatment or whether they should taper it. Tapering SRIs have their own risks, including rebound symptoms like anxiety, and then there's especially some antidepressants with stronger withdrawal risk like venlafaxine and paroxetine, in which the risk benefit may not be there. So let's talk about the outcomes of some of these studies for psilocybin. What are some noteworthy trials done with psilocybin? Well, there have been published studies on TRD, or treatment-resistant depression, that are definitely worth mentioning, as well as studies on anxiety and depression with life-threatening illness, as well as a study on tobacco cessation, demoralization in AIDS survivors, and alcohol use disorder. There are several other studies in the pipeline. By the time that you're seeing this, there may be other ones, new ones that aren't quite out yet, but some other studies in the pipeline include mild cognitive impairment in Alzheimer's, anorexia and body dysmorphia, cocaine use disorder, OCD, depression and bipolar II disorder, and headaches, including migraine cluster and post-concussion headaches. So let's begin by talking about depression. What studies have been done with psilocybin in depression? There have been 3 very important published studies. The first one was in 2016 by Carhart-Harris and colleagues. It was an open-label feasibility study, a smaller study with 12 participants, where it was 6 men, 6 women, aged 30 to 64, who had been diagnosed with moderate to severe treatment-resistant depression. They found that psilocybin was well tolerated by the patients with no serious adverse events reported. Then Davis and colleagues in 2020 published a randomized controlled trial of 24 participants with major depressive disorder and found that those who received immediate psilocybin-assisted therapy compared with delayed treatment, because they instead of having placebo versus treatment, they had a placebo versus treatment and then crossed them over. So they show that those that had the immediate treatment showed improvement in blinded clinician rater assessed depression severity, and in self-reported secondary outcomes through the 1-month follow-up. And then Carhart-Harris in 2021 published a psilocybin versus escitalopram, the antidepressant, SRI. They did a comparison in a randomized double-blind active controlled trial that was looking at the non-inferiority. Basically, is psilocybin non-inferior to escitalopram, which is widely used and prescribed for depression? And what they found is that it is not inferior. So, similar in antidepressant effects, and that there were some secondary outcomes that did favor the psilocybin over escitalopram. So in these trials, they were looking at both a dose of psilocybin as well as preparation therapy and ongoing therapy sessions and follow-up sessions and visits afterwards. So psilocybin for treatment-resistant depression. This is the first study that I had mentioned. Davis and colleagues randomized delayed clinical trial. This is the second one that I mentioned. Davis and colleagues 2020 randomized delayed condition trial. Here's where you can see the one group that got immediate treatment versus the other that got delayed treatment. And what you can see is that big drop in depression scores, the HAM-D scores, in those that got the treatment. So there's a 71% response rate. Response means greater than 50% symptom reduction. So, if somebody's depression is 20 at first, then it's in 71% of those people, it dropped to below a 10. If that makes sense. And similarly, there's 54% remission, meaning no longer meeting criteria for major depression. So over half of people that got the treatment ended up no longer meeting criteria for depression, which is pretty significant. And then the 2021 trial that I mentioned, this is the non-inferiority one. It had 59 participants, so a bit more robust, and it did demonstrate non-inferiority in its efficacy compared against the escitalopram. The other thing is that there were some side effects noted, including headache and nausea, but less side effects overall compared to the escitalopram group. So less side effects than the antidepressant. And escitalopram itself doesn't have, it does have side effects, but compared to other SRIs, in many ways it has less. So it is good to know that psilocybin has less side effects overall. Psilocybin increased emotional intensity, while escitalopram decreased it. And secondary outcomes included that there were higher pleasure ratings, loss of anhedonia, greater well-being and flourishing in the psilocybin group. So all this is pretty hopeful. There is an ongoing phase 3 trial. This is being led by Compass Pathways, who is the developer of psilocybin medication. And it's this COMP, C-O-M-P, is their substance. So their phase 3 program has 3 clinical trials, including 2 pivotal trials and 1 long-term follow-up. So the pivotal trials include pivotal trial 1 that has 378 subjects in it, and they're getting a single dose of 25 milligram monotherapy compared with placebo. And so it's designed to replicate the treatment responses seen in the phase 2b study. And the pivotal trial 2 has 568 subjects and is using a fixed repeat dose monotherapy with 3 different arms, a 25 milligram treatment arm, 10 milligram, and a 1 milligram treatment arm. So this is looking at whether a second dose can increase number of responders and improve response, which is interesting and good to know. Whether is one single treatment session enough, or is there any benefit to having multiple treatment sessions? All right, and the primary endpoint in both pivotal trials is the change in baseline MADRS scores, which is a depression score at week 6. So that's it for depression, although the next section here is definitely related. This is anxiety and depression with life-threatening illness. So this is largely referring to the research done at Johns Hopkins that is looking at folks that have a terminal cancer diagnosis and have all of the anxiety and depression related to that diagnosis, and looking at what is the role of psilocybin in treating these issues. So again, most of the subjects have a cancer diagnosis, a mix of anxiety and depression-related symptoms. But what they're trying to get at here is this existential crisis of, recognizing that one is going to die soon, and how to deal with the mood and anxiety symptoms that come up as a result of that. They did exclude patients that had central nervous system metastases, paraneoplastic or endocrine tumors. They permitted chemotherapy, radiation, and long-acting pain medications during the trials. There were 3 double-blinded RCTs with 92 total participants, and used a dosing of 0.2 to 0.4 milligrams per 70 kilograms. And They had 1 to 2 sessions over 4 to 7 weeks that were separated in a crossover style, in which one was psilocybin, one was placebo. For placebo, they were using niacin or a very low dose psilocybin, and they included preparation psychotherapy and integration psychotherapy weekly. So they were, within the sample, they were including folks with any stage of cancer included, as long as it's considered life-threatening and progressive, but the patient had to have good functioning. So, they weren't able to include everyone in the studies. What they found, though, is that for depression, there was 60% remission versus 16% in placebo, which was significant, and 80% versus 15% in another study. The anxiety scores revealed 52% remission versus 12% remission in placebo. So, all this is very powerful. The number needed to treat is 2 to 3, which means that, for every 2 or 3 people that are treated, one of them will go into remission. So very powerful results. The endpoints they varied in the studies between 5 weeks to 6 months of follow-up, and they were looking at anxiety and depression scores as the primary endpoints. So it's thought that specifically, if you remember back to the mystical experiences questionnaire, the MEQ, that specifically these reports are on ego and ego death, or sort of the loss of your own individual identity and kind of feeling yourself merging with everyone around you, the sense of unity, that's what helps with this existential crisis. That as you're dying and you're thinking about your life, that the more that you can sort of see yourself as part of everyone else and everything, the more helpful that is for the depression and anxiety symptoms. It's also thought that neuroplasticity plays a role, which is definitely feasible, and that is people have improvements in their neuroplasticity, their ability to make new connections in their brain, that helps with developing new insights in therapy and with integrating that, sort of changing your mind in a very literal sense. So the next study I want to talk about is psilocybin for AIDS demoralization. This was a really interesting study. It was a trial of psilocybin-assisted group therapy in older long-term AIDS survivors with demoralization. So they included gay identifying men aged 50 and up with an HIV diagnosis prior to 1996. There were 3 groups of 6 participants, or 18 total, with 3 hours of individual therapy, 8 to 10 group therapy sessions, 1 group psilocybin session, and many comorbidities were included, including 3 patients that had borderline personality disorder. So what they found is that there were improvements in demoralization. The group therapy was sort of ended up being focused on addressing isolation, stigma, shame. The 2 of the patients with borderline personality disorder diagnoses had trouble integrating in the group, but it generally demonstrated safety and feasibility of psilocybin within the context of group therapy, which is pretty novel. So what other studies have been completed with psilocybin? Well, there have been positive and clinically meaningful results for alcohol use disorder. That was by Bogan, Schultz, and colleagues in 2015. Tobacco use disorder, Johnson and colleagues published this in 2014. There were high quit rates that were shown. It was a small study, still needing replication, but very hopeful. And then also OCD. Moreno and colleagues in 2006 published a study. So all used a series of psilocybin sessions rather than a single session, and there were no published negative studies for psilocybin. So all of this is kind of an area of opportunity for the future, whether these things will pan out to be future indications. What risks have been noted with psilocybin? This is very important. With any of these new treatments, there can be a sense of that something's a panacea, that it's going to solve everyone's problems, but it's really important to take into account the risks and the benefits. So the risks here include psychiatric side effects. So Some can have psychological discomfort, like what's experienced in a quote-unquote bad trip. Somebody that may have an anxious ego dissolution, like I had described before, that may be more likely with typical antipsychotics. So some experience anxiety, confusion, or thought disorder, hallucinations, paranoia, psychosis. So for that reason, it's often a contraindication in trials if somebody has a diagnosis of a psychotic illness like schizophrenia, or if they have a history of bipolar 1 disorder. There are neurological side effects, mostly including the post-use tension headache that is commonly seen. So people often have headaches in these trials after the treatment. And there are some transient cardiovascular side effects, including an increase around 25 millimeters of mercury in systolic blood pressure, 10 millimeter mercury increase in diastolic, and 10 beat per minute increase in heart rate. And there's risk of nausea and vomiting as well. Going on about the risks that have been noted with psilocybin, there are very low rates of physical harm resulting from psilocybin noted in trials. There is no significant risk for lethal overdose, and that's, like I mentioned, due to the partial agonism at the 5-HT2A receptor, meaning that there's lower risk for serotonin syndrome, which is deadly, but again, is not considered much of an issue for psilocybin. The low rates of physical harm are also related to low addictive and reinforcing attributes. So folks develop rapid tolerance, and so that helps with the low addictive and reinforcing attributes, meaning that they sort of need to take a break between sessions in order for them to have much of an experience or to feel much. And psilocybin is associated with lower hospital admissions, seizures, and generally less side effects than many of the other psychedelics studied. So it's thought to be very well tolerated. The risks are largely associated with the vulnerable and non-ordinary state of intoxication, as I mentioned, including risks of psychosis and, the vulnerable state of somebody when they're in a treatment session, and in people that aren't in treatment sessions. Just something I want to mention quickly is that, as this research has come out about psilocybin and the possible benefits and possible medical indications that there will be possibly in the future, there have been people that have been using psilocybin or microdosing at home or using it on their own. And what's really important that I hope folks gather from this is the importance of set and setting. That a trip that somebody can have depends a lot on what sort of environment that they're using in, and the dose is very important as well for that. And so, like it mentions here, being vulnerable and having this non-ordinary state, we do see people. I've seen people, come into the emergency department in some sort of crisis or psychosis after ingesting psilocybin. So it's important to take that into consideration. It's illegal, and it's not something that's been found to be safe to be used outside of the medical setting so far. So long-term or chronic use may be associated with valvular heart disease, and there's possible concern for exacerbation of psychotic or manic illness, derealization or dissociation, like I mentioned, which is why it's generally considered contraindicated for people with a history of psychotic illness or bipolar 1 disorder. So here's a summary about psilocybin. It is a tryptamine psychedelic, as mentioned. It's 5-HT2A partial agonist with a good safety profile. Psilocybin-assisted psychotherapy appears to have benefits for multiple indications, including depression, anxiety, and life-threatening illness, substance use disorders. Psilocybin-assisted psychotherapy has been safely conducted with medically ill patients, including those with cancer diagnoses and AIDS, and is generally well tolerated with risks primarily related to drug-drug interactions, which see in lithium the risk for seizure and intense psychological effects or psychosis. So that's kind of some of the ways of weighing the risks and benefits about psilocybin. I thank you so much for listening to this, and hope you find it to be interesting. As always, you can follow along at Brain Health with Dr. Nissen, listening to our podcast or seeing our content wherever it comes. So stay tuned. There will be more information coming about psychedelics and interventional psychiatry soon. Thank you.